Here a logarithm about what we have said about the male infertility. We have seminal fluid analysis, and the result of the seminal fluid analysis either normal, which means normal seminal fluid count and motility and everything of the parameter is normal, or sometimes we have oligospermiates, mean the count below than 20 million per mil of the ejaculate, or sometimes we have an azoospermiates, mean there is a zero count. And according to the WHO, the seminal fluid analysis give an idea about the probability of the male to be fertile. It means that the male who exceed the normal parameter, as an example, that the sperm count more than 20 mil, it's more probably to be fertile. But the male who has a low sperm count, below than 20 mil, it's more probably to be infertile, but it is not a must. The only result that can I say that this male is sterile is the azoospermia or zero count within the seminal fluid analysis. Otherwise, oligospermiates could be fertile without any treatment, and even normal count could be fertile without any treatment. So, if I have a normal seminal fluid parameters, the first thing I should reassure the patient, and I should encourage him, and I told him not to be worried, and I told him also to give up certain bad behaviors like alcoholism or smoking. If it is not used, or if this parameter is not useful, I send him for a clomid. I give him a clomid. Clomid, this will stimulate the follicle stimulating hormone and luteinizing hormone by indirect negative stimulation mechanism, and will stimulate the follicle stimulating hormone and luteinizing hormone. This will increasing sperm count or even sperm production. I can give him certain tonics like vitamins, and this will increasing activity of the sperm. Multiple vitamins used like vitamin E or vitamin C or a certain antioxidant agent. If I have a normal sperm count and high grade varicocele like grade 2 or grade 3 varicocele, I should advise him to do varicocelectomy if it present. Sometimes these parameters or this measure is not useful for the patient, and the patient is maybe or the male maybe or the couple may be hurried to have children. So we try first intrauterine insemination, we call it IUI, and sometimes we shift him directly to in vitro fertilization, or even exit procedure, we call it the intracytoplasmic sperm injection. What about the oligospermia? Oligospermia is defined as the sperm count of below than 20 million sperm per mil. We have also sub-classification for oligospermia. If the sperm count between 10 to 20 million, I should look for varicose. If it is present, I should do varicocelectomy. For the presence of infection, if present, I send the patient for semen culture and sensitivity and directed toward it. If also the reassurance and smoking and alcoholism, the patient, I advise him that he should give up. If this measure not useful, I send also for IUI or IVF or XZ procedure. But what about if I have an oligospermia with count less than 10 mil? In this condition, I have to send him for hormonal evaluation by FSH, LH, prolactin, and testosterone, because any count less than 10 mol per millimeter, I can expect, or I should expect, there is abnormal hormone for him. There is abnormal hormone study or abnormal hormone measurement in this patient, and if any of this hormone is abnormal, I should direct my treatment according to it. For example, if I have low FSH or low LH, I should give him recombinant FSH injection or recombinant LH injection. We called it pregnil and pergonal for a period from 3 to 6 months. If I have a high level of prolactin, I can give him multiple agents that decrease the serum level of prolactin, like Dostinex or even Palodil. And also I should look for other causes like varicocele, infection, smoking, and directed my treatment to it. If this parameter is not useful for initial management, I shift the patient for IUI, IVF, and ICSI. This is about the oligospermia. What about the azoospermia, which is considered the most complicated cases in patients with male infertility? Azoospermia, it means zero count. It means there is no count or there is no sperm in his seminal fluid analysis. In this condition, I have to shift the patient directly into testicular biopsy. I should send the patient directly into testicular biopsy. Actually, azoospermia should be confirmed, as I said, with 2 or even 3 labs in order to make final decision for testicular biopsy. And after the result of testicular biopsy appeared, it's either normal testicular biopsy. It means that the patient has a normal testicular pathology or testicular histology, but there is no sperm count in the semen. It means that the patient have what we call an obstructive azoospermia. What is the causes of an obstructive azoospermia? It means there may be problem in the epididymis, or problem in the vas deferens, or a problem in the seminal vesicle, and all of these problems can be diagnosed easily by ultrasound or even examination regarding the epididymis and the vas deferens. And a transrectal ultrasound, we send him regarding if there is a problem in the seminal vesicle or the ejaculatory duct. In obstructive azoospermia, the testicular biopsy usually appear normal, and also there is normal FSH, normal LH, normal testosterone, normal prolactin. When I have this result, when I have normal testicular histology, normal level of hormone, the condition should be categorized under the title of obstructive azoospermia. And the obstructive azoospermia, as I said, at multiple levels can be happened from the epididymis up to the ejaculatory duct. For this patient, if there is maybe previous trauma to the vas deferens due to previous hernial surgery or undescended testis, I do for him vasovasostomy or even vasoepididymostomy, but all of these procedures are associated with low success rate. So I send the patient directly if I have an obstructive azoospermia and no correctable cause. I send the patient for ICSI procedure or even IVF or ICSI procedure. But if I have non-obstructive azoospermia, it means that the histopathology of the testicular biopsy is abnormal. Here we call the condition a testicular failure, and the testicular failure either primary or secondary. What about the primary? The testicular failure in primary, the histopathology, we have 4 types of histopathology for primary testicular failure. The first one is sclerosis, and this happened due to previous infection, especially mumps orchitis, and also we should look for the history for the patient if he has mumps previously, because mumps can affect about 10% of the child with mumps orchitis can have an orchitis in his testis. We call it mump orchitis. This means 10% of the patient with mumps will have mumps orchitis, and mumps orchitis will end with sclerosis. We have also in primary testicular failure other histopathology. We call it hypospermatogenesis or maturation arrest or even Sartori cell-only syndrome. This case, which is under the title of non-obstructive azoospermia and the title of primary testicular failure. Primary testicular failure, it means there is abnormal histology or abnormal histopathology within the testis, and also there is an increase in the follicular-stimulating hormone, an increase in the luteinizing hormone, and decrease in the serum level of testosterone. Why this hormone is increased and this hormone is decreased? Why? Because the testes have no normal spermatogenesis, have no seminiferous tubule. So in order to stimulate the testes to introduce a sperm, this will increase, and this will be low or even normal or low level, because there is no normal testicular tissue. So the FSH and LH, in order to reduce the testes, will be increased. Otherwise, the testosterone either normal level or even low level. For this patient, I should send him for EXI, looking for sperm from these histopathologies, looking for one or more sperm in order to fertilize the ovum. Other type of testicular failure, we have the secondary type of testicular failure. And the secondary type of testicular failure, in this condition, also we have azoospermia, but here the level of FSH and LH and testosterone is low. Why is low? Because the problem from the hypothalamus or the pituitary gland. When I have a decreased level of luteinizing hormone and decreased level of follicular stimulating hormone, whatever the cause, there will be effect on the spermatogenesis and resultant formation or resultant azoospermia. So in secondary testicular failure, I have low FSH, low LH, low testosterone due to Kallmann syndrome, and this Kallmann syndrome that affect the hypothalamus. Some rare syndrome affect the hypothalamus, which is due to low luteinizing hormone and low releasing hormone of the luteinizing hormone, and releasing hormone of the follicular stimulating hormone is so low from the hypothalamus. So it will result in the testicular failure, or what we call it secondary testicular failure. And sometimes also we have a pituitary tumor. A pituitary tumor also may affect the FSH and LH production and formation of testicular failure. And also we have anabolic steroid, which is used by bodybuilder. Because of high level of androgen in the circulation, this will cause negative feedback mechanism of FSH and LH, and finally the FSH and LH will be near the zero level, and this result in azoospermia. For this category, it's easy to treat it by giving the patient recombinant FSH and recombinant LH for a period of 6 to 12 months, and within 6 to 12 months we can see sperm appear in the seminal fluid. Actually, a patient with secondary testicular failure can be treated easily by giving up steroid hormone, anabolic steroid, and giving him follicular stimulating and luteinizing hormone recombinant injection. We call it Pregnil and Pergonal for 6 to 12 months. While for a primary testicular failure, it's difficult to be treated by drug or hormones, or impossible to be treated by hormones. We send him for EXI, and this logarithm of management of male infertility according seminal fluid analysis, I think it is very easy and can concentrate on the subject as a whole, and also consider as an abstract for what I said throughout the previous hour. Thank you very much, and I hope you get benefit from this lecture. And also I hope that we will see each other in next few couples of days. Thank you very much.